Hello, welcome back. Welcome to our biomedical engineering double feature for the day. Many of us know Dr. Binu Thomas well, as he's been a major figure at the Advanced Imaging Research Center at UT Southwestern for several years. He earned his PhD in biomedical engineering from UT Arlington and UT Southwestern's joint program, working with Dr. Hanzong Liu. Followed by postdoctoral work at UT Southwestern's AIRC. He's currently an assistant professor, now on the tenure stream. Congratulations. In the AIRC Radiology and the O'Donnell Brain Institute. And his work focuses on vascular contributions to health and disease, including aging and pulse sequences to improve their study. His talk today will be on metabolic and vascular influences on brain function, the role of diabetes, obesity, and hypertension. Let's welcome Dr. Binu Thomas.
Thank you so much, Kristen, for the invitation and for the introduction. I'm very happy to be here. Been here in the past, but back. Okay, so I think I'll get started. So first, I will talk about older adults with type 2 diabetes. This is a study that we recently started. We'd like to assess cerebrovascular function and both before and after GI and GLP type treatments. Then I will talk about a clinical trial that I'm part of to assess effects of hypertension on brain vascular function. And finally, I will be talking about a small portion of the Dallas Heart study that we worked on. Look at the effect of waist circumference, oxygen extraction fraction. I'm sure most of us are aware that obesity keeps increasing, and right now we're about 42% obesity adults, and even childhood obesity also increasing. Give you a better perspective, in the 1960s and 60 or so, we were under 15%, but soon around 2000, we more than doubled that number. And right now we are around the 40%. So it seems like a serious problem. See that. So along with obesity comes these other comorbidities like hypertension, there's hyperlipidemia, there's diabetes, mellitus, and all this eventually leads to increased risk for Alzheimer's disease. And this trifecta, that is aging and obesity and diabetes combined, actually does pretty bad stuff for your brain. So in general, systemically, it increases glycemia, insulin, as well as insulin resistance. It worsens the oxidative stress on the brain, inflammation, adipokines go up, and also the vascular function and mitochondrial function is dysregulated, which actually leads to eventually. So we proposed a model here where adults with type 2 diabetes and obesity, insulin resistance goes up, which actually leads to endothelial function decrease and reduction in nitric oxide release, which again reduces your blood flow to brain, microvascular compliance decreases, and vascular resistance actually decreases. Then there's also the CSF and interstitial fluid exchange also reduces because of paravascular or perivascular spaces that are as well, with vascular function decreasing. And with all this, the clearance of amyloid and tau person, that actually ends up building on. Eventually, there is chronic ischemia and blood-brain barrier permeability worsens, and oxygen extraction fraction decreases, and cognition worsens. Increased risk for aging. So this is our hypothesis. We expect that with obesity, just older adults with diabetes obesity have an elevated risk for chronic dementia. And so what we've done so far is we've assessed blood-brain barrier permeability, novel sequence, measured blood flow, oxygen extraction fraction, oxygen metabolism. This is the metabolic function of the brain tissue, and cognitive function. then eventually we have a small subgroup of people that have actually undergone some treatment of GIP and GLP-1. And look at the same assessments after treatment. So here's the study design, the inclusion and exclusion criteria. Recruited subjects with the age range of 60 to 80 years. The BMI is pretty elevated for the obesity and diabetes group, 30 to 45, but this here control group is in the normal range. HbA1c, we recruited a group of HbA1c people with HbA1c of 6.5 to 10 in the past 6 months. Here it was under 5.7, which is category for normal glycemia. Hypertension, we left it as controlled hypertension, so they could be on medications for hypertension. And of course, don't fit into the scanner when you have patients. None of the patients or controls have any existing ecological or psychiatric conditions, and no weight loss or bariatric surgery or weight loss. GI. So here's the demographics information. As you can see, their age, sex, and education matched. The BMI is severely elevated for the type 2 diabetes patients, and so is the waist to height ratio. The glycemia markers are all worser in the patients. This is fasting plasma glucose, that's also elevated, insulin and insulin resistance. The blood pressure is controlled with medications, and the total cholesterol and HDL was slightly elevated in the, or was better in the controls. And you can see that the patients are more of the patients are taking antihypertensive medication, so it is a comorbidity with obesity and diabetes. So just wanted to give you an outline of what the BBB sequence does. So basically what we do is we label the blood, the region around the neck, and wait for that blood to arrive into the capillary tissue interface. So this here is shown as capillary tissue interface and the venous drainage out here. So as the blood arrives, it exchanges at the capillary and the tissue interface, and eventually some of it will get drained into the venous side. And we actually image on the venous side that says how much of that labeled blood has arrived to the venous side. So we don't use any contrast agent for this technique. If contrast agents are used, then it's a large molecule, and we're pretty much looking at leakage of larger molecules. So, but this is a leakage of small molecules such as water. So how permeable is the BBB to water? So it's an early indicator for vascular function. And it's a global measurement, meaning we measure or we assess the amount of labeled blood that arrives into the venous side in the superior sagittal sinus. It's one of the largest draining veins. And it's calculated using this measurement. The E is the extracted fraction of the labeled blood into the water, into the tissue, and then the 1 minus E is what's drained into. So permeability surface area product, or the BBB permeability, is calculated using this equation, and F is the global flow, how much blood flow is arriving into from the neck. So when your BBB is intact, it permeates small molecules, but over time it starts leaking. More of the small molecules can easily come in and out from the. Over time, it can get worse, and larger molecules start to like contrast agents or so. So this here is some results that we have from the type 2 diabetes and control subjects. As you can see, the control and label images are required for each subject, and the difference actually highlights how much of the labeled blood is leaking into the venous side. As you can see, there's the difference image, or the difference between the control and label is minimal here, meaning that most of the blood that's been labeled is actually leaking out on the venous side, and that's why there is less difference in the type 2 diabetes patient. And you can see that permeability surface area is severely elevated for the patients. The blood flow itself is not different, so just the PVP permeability is leakier in patients. And this has been previously shown that patients with mild cognitive impairment actually have here the suggest that PVP is similarly leaky in fatty disease. Next, we assessed something called oxygen extraction fraction. This is measured on the venous side, and we use a sequence called quantitative susceptibility mapping, where we acquire 4 different echoes of data, and from that, actually using the difference between the oxyhemoglobin versus deoxyhemoglobin, the properties, the magnetic properties of oxy and deoxyhemoglobin, we actually measure, we actually image, get signal from the veins, and then from that we actually extract how much is the extraction fraction of oxygen. And this is the equation that we use. So again, it's the difference between the oxy and deoxyhemoglobin susceptibility on the MRI signal capture at the oxygen. And you can see that oxygen extraction fraction is significantly lower across the brain in these type 2 diabetes and oh, sorry, I think this is correct. So this is the patients are in red, then controls. That's a typo. So the oxygen extraction fraction is severely lower in the patients compared to controls. And we also have a measure of blood flow through different regions in the brain. And we, from that, we actually plug it into this oxygen metabolism equation. And actually, both are flipped. So meaning oxygen metabolism is also lower in patients compared to the. But this is across the different regions in the brain. So different, for most of the brain, you can see that OEF, oxygen extraction fraction from oxygen patients. And we've actually shown this in the past. So in mild cognitive impaired patients, you can ignore this C portion because this is the arterial oxygenation and Y8. And blood that arrives to the brain is pretty much 100% oxygenated. That's why the difference. But and neither is the blood flow. That is also not different from the controls and the controls of nestic MCI. You can see that the nestic MCI have lower oxygen extraction fraction compared to the controls. And oxygen metabolism is also lower mild cognitive impaired patients compared to controls. Oxygen metabolism being lower suggests that maybe their neuronal tissue is not metabolically active. And in fact, we also show that the higher the long-term delayed recall memory of a subject, higher is the oxygen. So in a sense, their brain is metabolically active. So blood flow is measured using this ASL sequence. I think most of you all probably used this one, the all introduction as well. The labeling slab is in the neck region where we actually invert the blood that's entering into the brain. You can see that the signal is flipped. Then we wait for a certain delay and we acquire the images of the entire brain. We do this again in a control acquisition, and in this we don't label, we don't invert the signal, but we just let it wait. We just wait for the same duration and we acquire. The difference between these two is the ASL signal or the arterial spin signal, and plug that into this equation. And shown here is the blood flow map for a typical older adult. See the nice gray matter and contrast. So then we compared the patients and controls, and we see that type 2 diabetes and obesity patients have lower blood flow, bilateral primary visual cortex, and superior cerebellum, hippocampus, and parallel. And typically around 40% or so blood flow is lower in these patients. Most of this work was done by and so this one is basically looking at the association between blood markers and blood flow. So you can see that higher the HbA1c of a patient, lower is their blood flow the brain. And same thing here, higher the fasting plasma glucose of the patient, lower their blood flow brain. Insulin resistance is also the same, that is higher the insulin resistance, lower the blood flow. And HDL seems to offer some protection, of course, the p-value. HDL seems. The HbA1c, higher the HbA1c of an individual, more leaky is there, shown here. And interestingly, all cholesterol markers, whether it's total cholesterol, including LDL cholesterol and HDL cholesterol, are protectable. So higher the cholesterol markers in general, it seems to protect. And interestingly, also oxygen extraction fraction. So higher the HbA1c across the brain, lower is their oxygen extraction fraction. So it seems like a viable group. And with regards to cognitive function, these are the tests that were done, and all these stars are the ones that are significantly different. And you see that the patients are performing slightly lower than the controls. So what this means is that the patients are not impaired, don't have a clinical diagnosis of any sort. Their function does seem to be lower than sex-matched control. And this is just in graphic form. Can the red after that using specific function domain, attention domain, so global cognition. And so then this here signifies that BBB permeability is significantly associated with cognitive function. That is, the more leaky the BBB is, the lower is the cognitive function across these different cognitive tests. And this has previously been shown in mild cognitive impaired patients. So worse or the more leaky the BBB is, lower is the cognitive function in mild cognitive impaired and subjects. And also this has been tested in blood flow. So higher the blood flow of an individual, higher is their total cognitive function. So it's K at the switching score, attention index at the switching score. Okay, so here's the interesting part. We have about 5 people who have completed GIP and GLP-1 medications. Of course, this is expected in here. After treatments, their HbA1c is now mid-range. So this is the pre-HbA1c and post-HbA1c. Interestingly, blood flow is elevated after the GLP-1 treatment. This cluster on the top of the brain is the pecuneus and posterior cingulate cortex. Blood flow is slightly elevated with subjects in the 5 patients that we had. And again, this is the occipital lobe. So it looks like blood flow is elevated to the occipital lobe. Somehow, so of course, this is just 5 subjects. So the process of adding more patients and study and see. Cognitive function wise, the cognitive function instrument is a number of issues they have with cognitive function on a daily basis. And that seems to have decreased a little after GL patients. And the R-band's digit percentile is also, of course, this is from 5 subjects. Oxygen extraction fraction is also being elevated after GIP, GLP-1 medications across the brain. Actually, more so in the whole brain, the cerebellum, occipital. And you just see a smaller, a lower number as far as DDD contributing goes. So what are the mechanisms, right? So GIP, GLP-1 medications actually protect the heart. They attenuate plaque formation. They decrease lipids in the body. And they also have an anti-inflammatory effect. They do actually support kidney function, vasodilation. This was a study that was performed in rats. So they gave rats a high-fat diet for about 24 weeks, and then they split them into two groups. One group got GIP, GLP-1 medications, and the other one got saline treatment. And they observed that many benefits were observed in the GIP, GLP-1 saline. You can see that the triglyceride levels were lower. They even observed increased cortical capillary density, improved astrocyte coverage. The astrocyte end teeth were more located on the blood vessels. Decreased leukocyte rolling, meaning more leukocytes or lesser leukocytes were freely moving in the bloodstream. There's restored hippocampal thickness, increased adipocyte tissue with increased levels of insulin. So what really is happening here in this treatment is basically GLP-1 receptor agonists actually go and activate the GLP-1 receptors, and this is there across multiple different organs of GLP-1 receptor. They actually undergo two different types of alternate pathways. One releases calcium. It actually leads to a variety of improvements. It increases beta cell insulin release. Smooth muscle cell proliferation is decreasing. So that has something to do with atherosclerosis. Platelet reactivity reduces, and so does bone cell formation and myeloid. Myeloid recruitment actually has something to do with tumor factors. There's also vascular regenerative cell progenitor cell increase. And what that does is actually it supports or increases endothelial cell dysfunction and death. So it regenerates some of the vascular cells. In this alternate pathway, actually, you can see that the oxidative stress is reduced. Nitric oxide is released. Inflammation also. And this year, what they did was they actually took sections of the mouse brain or the rat brain, and they labeled them for GLP-1 receptors. You can see that GLP-1 receptors are shown here in red. Smooth muscle actin is shown here in green. The lectin is, or endothelial cell lectin is shown here in light blue. And you can see that the GLP-1 receptors are there across the entire length of the arteriole, penetrating arteriole. And you can also see that it's also present on the surface vessels in the cortex. And even across tissue, actually, you can see that GLP-1 receptors are across tissue, various locations. So this is probably how benefits are observed. So to summarize, type 2 diabetes and obesity have lower blood-brain barrier permeability, integrity, lower blood flow, lower oxygen extraction fraction, and oxygen. Cognitive function is also suggestive of and of course, the effects of GIP, GLP-1 medications are so far only in 5 patients, but this needs to be controlled. Next, I'm going to talk about a clinical trial that I'm part of. What we've done is try to assess blood flow pulsability, in how pulsatile the blood is as it arrives into the brain. We also assess vascular reactivity in hypertensive older adults. All of this was done using resting state. This is a part of the clinical trial, like I mentioned. I'm reporting cross-sectional results here. The treatment results are not yet assessed or analyzed. This is we split the patients into two groups. One is aggressive treatment, meaning bring their hypertension levels below the 120/80 prescribed numbers. And the other is the typical treatment, the standard of care, where they adjust it to older. So this here shows the demographics. You can see that the controls and hypertension folks are age, gender, and BMI. Sorry, age and sex matched. BMI, interestingly, is elevated in the patients, again suggesting that all comorbidities that exist together. Obesity is also higher in the hypertensive group. The mini mental state exam was about similar across groups, so they're pretty healthy and they seem like control participants. HbA1c was not different. The 24-hour systolic blood pressure, diastolic blood pressure, and not even further, as expected, was higher in these patients. So most of this work was done by SLE. So basically what we've done is we actually assess the pulse wave amplitude of the blood that arrives in the brain. We actually are able to differentiate between what's arrived in the vein. See that the vein is a little bit lower than that you see in the arteries. And this here shows the pulse wave amplitude of the blood that's in the circle of Willis here. And in the vein, you can see that the pulse wave amplitude is lower. So what's done here is we hypersample the MRI. So assuming you're acquiring a 2-second PR, it's hypersampled so that we sample it down by be about 500 to 800 seconds or so. And then we extract the cardiac information from the resting state. This here actually appreciate the amount of pulsatility or pulse wave amplitude that's flowing through the circle of Willis. So most of this data is from the arterial side. Of course, you can see some. And we also assess vascular reactivity. So what is vascular reactivity? So it's the ability of blood vessels to vasodilate in response to vasodilated agents such as carbon dioxide, where the pressure of carbon dioxide actually increases in the brain. And you can see that the arterial blood vessels have this ring-like structure, which is called the smooth muscle cell. Those are the ones that dilate. This it's devoid. The smooth muscles are not on the left side, and we don't expect them to vasodilate. So here's a mechanism of how CO2 actually causes vasodilation. It actually triggers the endothelial cells to release nitric oxide synthase, which then actually increases the nitric oxide availability, crosses the onto the smooth cell side and causes relaxation, and that's typically how vasodilation occurs. But what we've done here is we looked at resting state-based data. So we actually filter the data in such a way that we arrive at a time course, which is a closer indicator of CO2 in the lungs. And then we use that for regression analysis to vascular reactivity. So it's a global signal that we assess from the resting state data. And shown here as an example, you can see the whole time course is in green, the end-tidal CO2 time course is in blue. And if you bandpass filter both of these, you can see that the global bold signal is more correlated with the end-tidal CO2 signal. So we are arriving at a proxy of the end-tidal CO2 in the lungs, which is then used for CDR. And shown here is resting state CVR map on the top. and CO2 based, actual CO2 inflation based CPR. And you can see that the maps look pretty equivalent. And this here shows the cross correlation hypercapnia, CDR, and resting state based CPR. And this was also repeated for about 10 scans in. You can see the intra-class correlation is. And okay, so going back to the pulsatility maps, this is what a typical representative map for control pulsatility map brain for patient looks like. You can see that the hypertensive patients, the pulsatility is higher. Most of these regions are the circle of Willis, so higher pulsatility in the circle of Willis. And the difference, so here we show a difference between groups. So the hypertension patients have higher pulsatility in the anterior cingulate cortex. There is also, so this here is the circle of Willis, and also the hippocampus and the paracampus. And interestingly, you see the same in numbers here. So hippocampus, paracampus, rostral anterior cingulate cortex, and subgenual ACC. And so pulsatility is elevated in hippocampus, paracampus, and subgenual ACC patients. Shown here again is a correlation between 24-hour systolic blood pressure. You can see that pulsatility is elevated patients compared. Now I'm going to the vascular reactivity. So apparently we did hypothesize that hypertension increased vascular reactivity. Interestingly, it's only lower in the rostral anterior cingulate cortex. The hippocampus and paracampus also not observed in the vascular reactivity. So again, vascular reactivity is lower in patients compared to. And this here is a study that was done on 7 Tesla MRI by this group. And what they did was they did phase contrast MRI patients on 70. And they assessed how much of this pulsatility actually traverses from the middle cerebral one. So it's a larger artery to the smaller arteries. It's called the ventriculostriate say. You can see that the higher the mean arterial pressure of an individual, less it gets dampened arrives at LSA, meaning that from the middle cerebral artery, the blood is pretty pulsatile. But in a control individual, because of the compliance of blood, it gets dampened as it arrives at the smaller. The patients see that the pulse wave amplitude is actually arriving with higher force in smaller, it probably damages. So here's the mechanism. Hypertension actually elevates the oxidative stress. It lowers the nitric oxide release. Vasculature also releases a bunch of pro-inflammatory mediators, and platelet interactions will occur. It does affect the endothelial function as well. Eventually, does remodel the blood vessel, actually called constriction. Interestingly, I came across an article by Anthony Ross and Karen Rodriguez, and they do show that the frontal lobe is vulnerable across all the lobes in the brain to hypertension. So higher white matter hyperintensity in the frontal lobe. Shown here are the map of a patient, normotensive control, 77-year-old patient. You see that the white matter hyperintensity were significantly elevated. Interestingly, HDL cholesterol seems to be protective. Shown here is the expression of HDL cholesterol and CBR. You can see that the vascular reactivity is elevated. The frontal lobe, people that have higher HDL cholesterol. Now, this correlation was significantly associated in controls, but it's not evident in patients. So I think this has something effective in HDA. So to summarize, pulsatility is higher in the subgenual ACC, the campus and campus. These hypertensive patients, vascular reactivity, interestingly, was lower in the symphytic cortex, the symphytic cortex, and HDL cholesterol positively associated with CVR, suggesting some sort of protected HDL cholesterol. Finally, I will step into the Palace Heart and Mind study, and also this work done by Saisha here. And we had data from 255 subjects, and the mean age was 65. Shown here is a distribution of the middle-aged older sexes. And this is already known, so nothing new here. But as we age, oxygen extraction fraction just increases in the brain. So this is a global index. So it's not a Watson-wide measure, but the brain works harder, extracts more, needs to extract more oxygen every week. But interestingly, the mid-waist circumference was also significantly associated with ODF. So even after adjusting for age and sex. And so we did a mediation analysis. We observed that the age actually partially mediates effect on OEF, but that partial mediation is 4%. The waist circumference slightly elevates your age, which actually elevates OEF. But there's a direct effect. Still don't understand. We are interested in trying to study that more. Trying to look at body composition, that visceral fat, subcutaneous fat, fat muscles, percent fat. They will see if maybe some of those make sense. Extraction fraction. So to summarize, here the waist circumference was positively associated with extraction fraction. So partially mediated weight has a larger direct effect. If you are interested in studying that, I'd like to thank my lab members, collaborators, for all of these projects.
Thank you. Great talk, Vijay. I had curious idea, because I was just reading about the metformin being the wonder drug, which came out from Harvard. I was thinking, it's great that you have all this GLP, but it's still new and it's not available for everyone. Like I'm thinking about patients back in India or in a developing country or rural populations here, we might not have access to this drug. Have you thought about looking at metformin, because it has the same kind of effects on the kidney, and it seems to through these rural population data that has shown that it improves cognition and delays, and also improves cardiac. So all those variables that we're showing are also shown with metformin, but that might give you a larger population.
Yeah, no, but I think in the US, I think it's difficult to find. So I think there are quite a bit of folks on the GLP. Interestingly, they've already done some simulation trials with large population-based studies to look at first incidence of Alzheimer's disease and dementia. And looks like GRP and GLP-1s have a more effect, or they reduce the risk of first incidence of dementia, and also the risk of AD and RD or in people taking GRP. So
there's a combination. Like, do all these patients take metformin and GLP versus like ones who just take?
Yeah, so most of these people that I've done so far, the 5 that I've taken here have actually switched from prior medication. Okay. Were probably on sufficient patients, but they've quickly moved over we've seen a lot of improvements, seen about 17% on average. Yeah, we're just trying to understand the mechanisms of but of course, it would be great to compare people on these traditional medication. Compare with, yeah.
If it's more effective,
Yes.
GLP over and beyond.
Correct. Yeah, I've actually come across a paper that shows that SGLT2 inhibitors seem to perform slightly better. And actually, one emulation trial showed no difference with GLP concept. GLP.
What do you make about the posterior cerebral artery flow recovery in your work? Because we see it in the literature a lot. When you think about cognition and aging, the first thing you think about is kind of anterior type of flow. But if you really read the literature, a lot of the aging stuff is this posterior flow. Do you have any kind of thoughts on that?
Interesting for us too. I mean, that blood flow is significantly lower in the occipital lobe, but actually oxygen extraction function is lower. I mean, so people without any issues on their vision or so, but I think this is something to suggest the early indicators of maybe something like blood flow. It seems to be a burden on posterior circulation. Also, I think some people do show larger arterial transit time. So maybe the vasculature is more transit times to be. So
That's what I was kind of wondering, because you see it in just normal aging too. You see it in like the earliest papers of people studying this. I wonder if it's just simple mechanics, like only 20% of the blood kind of goes up the neck and gets to that part of the brain. Is it just that simple? Like, do you think?
I think it's something to do with the tortuosity or length of the vasculature coming into the case.
Okay.
Also, I think the anterior circulation is also low. I think that's probably why we see changes. I think they do have some competition.
Okay. Interesting. Thank you.
Great talking to you. I'm really fascinated about the GLP study as well. Specifically the time frame, the PH at 9 months. Is there a reason why you selected 9 months, especially with that titration? Is that just after you reach the stable dose? And if so, would you expect those changes to happen that quickly with the?
Yeah, so that's a very nice question, interesting question. So I think people do. So we were mainly interested in looking at large weight loss, at least like 15-20% weight loss, because I think obesity is a big changes, diabetes changes. So, yeah, so this BBB function is like an early indicator for mobility water. So it's not like a big structural change, but I think you see maybe some effects of vascular function differences before that. But this huge weight loss reduction, I think, has something to do with it, as well as the other mechanisms that we saw from that study. All these have to be confirmed on the sample side. We are recruiting more patients. We're also interested in looking at compound.
Just combining that one with the last study, which is like, very interesting about the big circumference. Are you also taking, I mean, it's three types of things now, but are you also thinking about not just total weight loss, but where the weight loss is happening? Like if the circumference, even if there is a 1 inch decrease in circumference, because usually 10 kgs of weight loss means, 10 pounds of weight loss means 1 inch of, waist circumference. So, is that significant? Is that good?
Yeah. So we are hoping to get to that. I mean, we have some data now from the visceral fat and liver fat and so on. So I think all of this will eventually suggest something. Definitely want to see there are changes in the circumference of the station.
Do you want to maybe speculate on the cholesterol findings, like what, like a, I don't know, an imaging confounder could be like having cholesterol in the blood and that being like a large molecule? Is there something like just hemodynamic wise or something that like it say it's not true? Is what could it be? Maybe like in the just do you know what I'm saying? Like say it's
about the data for
yeah. Why would
TB?
yeah? What if cholesterol isn't like actually protective? Is there any type of like confound that it could be like creating? Like just devil's advocate. What if cholesterol isn't good for you? It's something like just in the something downside of like imaging that like we haven't thought of could be like driving that. Or maybe I'm just completely wrong. But just like you're an engineer. I just figured I'd ask your opinion.
Yeah, so quite interesting results. I think so I don't know what about the bad side of cholesterol yet, but it's suggesting that it's protective of the vascular reactivity. It also seems to protect the BP, meaning I think cholesterol has something to do with bilayer formation, cell structure, cell structure. Yes, something.
So there's just because there's large particles and that's just helping with the barrier? Like
I think so. I think there is some tight junction formations and some of that I think is what we are seeing. Type 2 diabetes and obesity patients so far were just being divided more subjects because that cohort. I think we've added about 5 more each. And yet we should be looked at the data, but we want to see if these will actually survive.
It'd be a good target for a mediation analysis down the road, right? Stick it in the middle and see if it is mediating like the effects of something that's like detrimental to something good and see if it kind of mediates the middle of that. Huh. Cool. Yeah.
High HDL, which,
If this is good, if that is bad.
It's the HDL versus LDL ratio, which is even better predictive. Just overall.
Correct. Yeah, interestingly, LDL was also good.
Right. That's why I was like, it's like
It's hard to believe.
Yeah.
So, midlife, you mentioned that your control for sex, but did you actually do you have information about menopause for the female?
So all of these patients were post-menopause, so 60, over 60 years.
Only the older.
Yeah, all of our studies. Yeah, it would be interesting. There are other groups that are looking at.
Sure.
There are other groups looking at menopause and cardiac.
Thank you very much. Thanks for coming.